It's of A2 level, and I'm going to make more videos related to A2 level. Also, if you don't have any prior knowledge to what is schizophrenia, I would suggest you to go back to your books, read it, and this is just a revision video and nothing new. So it shouldn't be anything new for you guys. Let's move. So what you have to expect in this video is that we are going to talk about the diagnostic criteria using the ICD-11. So it's a revised version of ICD-10, which is International Classification of Diseases. We are going to do schizophrenia of it. Okay, so we're going to have two types of symptoms, positive and negative. Then we're going to do a case study, and then we're going to do, delusions, and then we're going to do the VR key study. So schizophrenia is a psychotic disorder. It means that a person with schizophrenia will lose the contact to reality. So according to ICD-11, a person need to have at least one symptom, core symptom, which is the positive one, for at least 1 month. And it should be that there are no other causes for that symptom to be happening. Like, for example, hallucinations may also be linked to alcohol, and that's it. So the person shouldn't be having any alcohol prior to the diagnosis. Okay. So positive symptoms have hallucinations, and you need to know what kind of hallucinations there are. And there is experience of influence, passivity, or control. So what is it? So again, for hallucinations, there are things that we are seeing an external stimuli which is not present, like hearing voices or, seeing things that are not there. And for experiences of influence, passivity, and control is that having a subjective, having a thought that is, you feel like you're being inserted by someone else, for example, aliens. You believe that you're having these thoughts because aliens have the control over these thoughts that you're having. Um, so this is it. So there are delusions. There are types of other delusions that we are going to cover in the next video. Not the next video, I mean next slides. The fourth is disorganized thoughts and behaviors. We know what those are. So for disorganized behaviors, that could be, a gesture which is deemed to be, inappropriate, or having a repetition of behaviors, or having and disorganized thoughts is maybe, so many thoughts coming in together, and there is, then makes incoherent speeches, for example, words that don't make sense. So for the negative symptoms, basically these symptoms, the negative ones, seem to be normal. For example, having a flat effect, having evolution, elogia, and sociality, and anhedonia. So if you don't know what these mean, I'm going to go through quickly to what it means. Flat effect means having no typical emotional highs and lows. Evolution means a person may not be able to have, goal directed behavior, for example, waking up in the morning, or, getting ready for school, the basic things. They might not be able to do that. Alogia is lack of speech. Asociality is having, withdrawal, social withdrawal, not interested in going out. Anhedonia is losing pleasure, or may not be getting pleasure from, like doing any task. So that is what it is. And the age of onset, for example, the prevalence is same for male and females, but males tend to, have earlier diagnosis, like early 20s, and women, mostly get late onset schizophrenia, like 40 plus. Um, so in children, it's hard to diagnose because the symptoms may overlap with other diagnoses like autism. So it's really hard to diagnose them with, schizophrenia. Okay, what are prodromal symptoms? I forgot about that. So it's a weaker version of positive symptoms, meaning that if there are hallucinations, or if there are delusions, then the person might be a little bit aware of the fact that it's not real, but then, weaker version, as I said, in hallucinations with positive symptoms, they are believing that the person or the object they're seeing is real. But in a weaker version, a person might know that, it cannot be there. Okay, this thing is not real, or, having a bad thought. So we are done. Now the case study of schizophrenia. So there's this boy who had a troubled home with an aggressive father. So when he was 10, his parents divorced, and he began living with his grandparents. And so he also suffered, from his schoolwork. And by the age of 12, he was not attending school. And he was irritable and sad and often got into trouble for fighting. So the symptoms were that he was hearing voices that teased him. He was suspicious of his mother, muttered, laughed, and shouted at unseen others, and spoke very little. Poor sleep, self-care, preferred to be alone, away from other people, lack of insight into his condition. Um, so the treatment was that he was given for sodium valproate. So it was a drug that treated bipolar disorder. His mood and behavior improved for a while, but then it got worsened. So then he was diagnosed with very early onset schizophrenia, which is VOS. His aggressive and violent outbursts, they increased, and he was often admitted to hospital. Okay. So it was a case study, so it was detailed, in depth, so it just increased the validity. Also, he showed prodromal symptoms as well. So the use of children's psychology, so the consent was taken from the boy. He was debriefed. He was told what was going to happen to him and what's this all about. Also, proxy consent was also taken from his mother. He was also told the right to withdrawal. So everything good over here right now. So application to daily life is that ICD-11, which it was only 1 month they needed for the core symptoms. But in DSM-5, it was at least for 6 months if the symptoms persist. Then they were given any treatment. But in ICD, 1 month, so it means that early treatment, better outcomes. Also, there were removal of subtypes, which was catatonic, paranoid, dimensional descriptors, meaning that the rating was done on different symptoms, on severity, and more reliable diagnosis. They're actually showing you the difference between the DSM-5 and the revised version ICD-11, and its strengths. Also, one child not representative of very early onset schizophrenic patients from other cultures. So it's India, so India has very stigma around it, and there was lack of cooperation between other family members or people in community. So it just worsened his symptoms. Also, ICD weakness is that um, it's difficult to diagnose due to symptoms overlapping. For example, hallucination and depression, and it could be due to sleep deprivation. So the clinicians are basically, they have to successfully eliminate other disorders like depression and other physical causes like sleep deprivation to have a reliable diagnosis. And the cultural difference, for example, in Maori culture, the Matakits are, they're prophets and they hear voices and they're highly respected in their community. But in the Western culture, if you hear voices, maybe pathological, it's maybe a sign of illness. So it could lead to a wrong diagnosis. Pause the video and do these questions by yourself. So right now we have completed a case study, and now we have to focus on the types of delusions. So there is bizarre versus non-bizarre. Bizarre delusions are basically, for example, believing that part of your kidney is gone or somebody has taken out your kidney, and, even though there are no marks of an operation or any stitches, but you just believe that your kidney is gone. That is a bizarre delusion. And the non-bizarre is that, for example, someone is spying on you. Someone is um, uh, complaining about you at office, and having these non-bizarre delusions, like having these kind of delusions. And there is grandeur, is thinking oneself, having exceptional powers, abilities, for example, being a superhero, or being invisible, and just grandeur. The word mean itself. So persecution is you believe that someone might harm you or someone is spying on you, and so Freeman et al., we are going to do more in persecution or persecutory ideation later in the slides. Preference is, oh sorry, not reference, is how in a situation or an event. It's an event that you have a personal significance for. And for example, you believe that you're given a sign on what will happen in the future. You know, just making something up yourself out of a situation. Then, okay, we are done with this. Now we have to go to the case study. So this is case study by Freeman et al. Freeman himself, Daniel Freeman. And let's move quickly. It's exploratory research. Okay, it means that Freeman actually wanted to explore the potential of virtual reality to eliminate challenges, such as misinterpretation of social interaction between, the clinician and the participant, or the person. Um, and so he wanted to see whether it eliminates these challenges. For example, a person in a normal setting, with a clinician or a psychologist, and on a sofa there is the patient, and then you're having a regular conversation. But a person with a mental illness, he might, develop the idea, for example, that this psychologist is, harmful. He or she is planning to kill me, or, make a wrong diagnosis, or, for example, having these ideas about the psychologist too. So Freeman wanted to eliminate this challenge. So the aims was, again, they wanted to see whether neutral or non-threatening avatars could provoke persecutory thoughts in people with no previous clinical diagnosis. So these people were not clinically diagnosed with any mental illness. Sample was non-clinical. And so they wanted to see whether it was common in people with higher levels of paranoia and emotional distress. So the method it was a correlational study. It was based on quantitative data and qualitative data. And so later both were scored further into quantitative data. So the sample was 24 participants, 12 male, 12 female. They were all paid, and so they were also volunteers. Their mean age was 26. They were all recruited from UCL, University College London in the UK, and they were all mentally well. Again, it was a non-clinical sample. 21 were students and 3 were administrative staff. You don't have to remember that, but yeah. So procedure was that first everyone was trained how to use the VR equipment, like the headgear or the handheld joystick, and they could move around with the joystick with the help of joystick and all that. Also, half of the sample before the task, the VR virtual reality task, they were 12. Half of the sample completed BSI, Berger, sorry, state anxiety questionnaire, and then there was paranoia scale. You should know what these are. So all participants completed the VR task. So it was a library. As you can see these images, it's a library, but they were not told that it was a library. Okay, so but it is a library, 3 in group and 2 in one pair on different desks, and all of them were doing ambiguous, behavior, like smiling, talking to each other. So participants were asked to explore the room, move around and think about what do you think about the people in the room and what do you think that they think about you. So 5 minutes into it, 5 minutes later, all the participants exited the room, all completed the BSI, SSAQ, and PS questionnaires. Um, all participants did, but half of them did it again, the ones who did previously as well before the VR task. So, and one group did it only once, which was after the VR task. So, it was also, all of them also did the VR paranoia questionnaire, which was 15 items that you can see over here. It was a new test. It was a new questionnaire made on this, situation specific paranoia to test that. It was measuring persecutory thoughts, ideas of, preferences, and positive beliefs about the avatars. As you can read, All of them, pause the video, read it. Also, interviews were also taken, qualitative data was collected. And they were also asked, in the interview, what do they think about the avatars? So videotape, it was all videotaped. Okay, every participant was videotaped. The psychologist rated out of 6, and looking for the indications of persecutory ideation, meaning looking at the videos and finding whether or not the actions or tendency towards it were visible by the actions of the participants. For example, if they felt distressed, whether they made a move that showed the feeling of distress. I hope that that you understand that. So the results were of the PS paranoia scale was 31.8. It was low compared to a previous study. Also, this is the 15-item VR questionnaire. It showed the level of agreement of participants. Um, Someone in the room had it for me. They were talking about me behind my back. They were friendly towards me. So there were more positive, beliefs about the avatars. As you can see, the numbers more positive, and less negative belief. But the negative beliefs were very negative. So yeah. This is the scale again. So the persecutory thoughts were from 1 to 5, and they positively correlated with the 6 to 10 over here. They all positively correlated with each other. And the interview, which was done, was also positively correlated. Ideas of reference, which was from 6 to 10, were basically negatively correlated with the positive beliefs that were, people got them from the interview, psychologists got from the interview. And the VR persecutory ideation was positively correlated with paranoia, interpersonal sensitivity, and anxiety, which was done by using the BSI. Okay, move. So it was a semi-structured interview on the beliefs, either positive or negative on the avatar. You can read, these are some of the comments made by the participants. Each comment was made by a different participant. So if it was one person was very shy and another had hated me, so it was by comment by one person. So the conclusion was it was consistent with previous research. Emotional processes linked to anxiety, interpersonal sensitivity contribute directly to the development of persecutory ideation, highlighting that VR holds great promise not only as a tool for enhancing theoretical understanding, but also as a way of helping individuals to evaluate and reduce persecutory ideation. And half of the participants answered BSI paranoia anxiety questionnaires before and after the VR experience, and only the other group was able to complete them after the VR experience. So this was done to see whether the participants, experienced persecutory thoughts happened while in the room, but this was not the case. It suggested that any such thoughts were triggered by the avatars, and it was not the overall procedure. So that just made us clear that it was an internal stimuli and not any external stimuli affecting, the persecutory thoughts. Pause the video and read this. So the study was both, nomothetic and ideographic, had these approaches. Pause the video. Then another application to everyday life. So we know that individual and situation explanations as well. Read it, pause the video and read it. So Freeman checked whether time spent in the room created any distress during semi-structured interview, and found that this was not the case. Also, anxiety scores were very similar before and after the VR task, suggesting that the experience did not leave the participant with any lasting psychological harm. So, furthermore, all participants gave their consent to take the part, although they were not told anything about the environment they were about to enter, and were not told this study was about persecutory thoughts. So this means that the consent was not fully informed, but given the stress-free nature of the VR environment, this was justified due to potential benefits to society. And one of the weakness was there was relatively low levels of presence. Participants felt that they were not there. Feeling of being not there, and so this was also measured by a 6-point scale in the previous VR studies, not this one. So the average presence was rated 2.3 out of 6. So higher the score, the more the present felt. So they did not felt much presence. And so it lacked the ecological validity, obviously, and it was not fully immersed. Participants were not fully immersed in the experience. So, due to this may be due to short duration in the room, for example, the 5 minutes, and relatively passive nature of the task. So another weakness was sampling bias. So the participants were all drawn from London University. They were all recruited via advertisements, leaflets, and they were all free from prior clinical diagnosis and relatively young. So the participants would have been relatively intelligent and interested in psychology and VR. So this means that findings may not be generalizable, to people outside of this population. So this is the questions. Do it. Your exam are based on these questions. So we did all of the 4 things that I wanted to do it in this video and what you guys expected. So the next video would be of, the other, which is the explanations for schizophrenia. For example, the biological have genetic, biochemical, and then there's psychological, which has a cognitive explanation to it. We will do all of this. Goodbye. Catch you in the next video.